We are public.
Oh, I've just seen them now.
Order, order. Good morning. This is the Health and Social Care Select Committee. We are in Portcullis House in the Palace of Westminster in London. Thank you for joining us, to those watching and to our guests who I will introduce imminently. We are talking NHS dentistry today. This committee published a reasonably well-noticed report last year on the state of NHS dentistry, which one of our guests' organisation described as a roadmap to save NHS dentistry. Today is a follow-up session to that and to the subsequently published Dental Recovery Plan for England, which the government published last month. So we'll be discussing all of that with Shawn Charlwood, Chair of the British Dental Association, General Dental Practice Committee, Rebecca Curtayne, who's External Affairs Manager at Healthwatch England, and Thea Stein, who is the Chief Executive at the Nuffield Trust, who published a very high-profile report on NHS dentistry, I think, just before Christmas. So thank you very much for joining us. We have a cross-party committee of members who are all ready to ask questions, and we will finish this panel and move on to the Minister in NHS England, the Chief Dental Officer, at 11 a.m. So I will start, and I will ask you, Mr. Charlwood, when we did the evidence session on our NHS dentistry inquiry, the then dental minister said the government's ambition for NHS dentistry was that we do want everyone who needs one to be able to access an NHS dentist. Absolutely. End quote. I was not expecting such an unequivocal answer to my question, if I'm honest. In many ways echoing Tony Blair's promise in 1999, just a couple of years into his government, that would also be the case. Are we in a place where former Minister O'Brien's ambition is on course to be met?
Well, thank you, Chair. I was surprised at the level of ambition at the last committee as well when that was stated. And much as I'd like to say that we are on track to deliver that, you will not be at all surprised to know that we do not think that's the case. And I am, as always, very grateful to this committee for this opportunity to present the profession's perspective on that question and on what is happening in NHS dentistry. And as you say, your report remains an instruction manual to save NHS dentistry. The government has, I'm afraid, given the impression that it's willing to skip over your first and most fundamental recommendation, and that, of course, is contract reform. And my colleagues are grateful that you continue to keep the pressure up on the department, behind the scenes, in the chamber, and in the form of today's session. And I'll be honest, having sat in negotiations for many months, my expectations of the recovery plan were pretty low. We waited nearly a year for this document, and my worry then was that with every day that passed, more colleagues would pare down their NHS commitment or walk away entirely. And now it's landed, I'm afraid there's really nothing here to bring this service back from the brink and deliver the promise that was made. But I didn't want to come here and just offer opinions. What we have done is surveyed the membership so that we can give you some facts. And having spoken to countless colleagues, the sense of disappointment and frankly resentment in the profession is profound. We surveyed, as I say, members. We wanted their feedback on this recovery plan today. And we were taken aback, frankly, by how brutal that feedback was. Government has told this committee, as you say, Chair, that its objective is to provide NHS care to all who need it. Well, we asked dentists if they thought the plan was capable of keeping that promise. 1% agreed. 1 in 100 respondents thought that this plan could deliver that promise. To answer your question directly, just 3% said the measures in the plan would keep them providing NHS care in the long term. 3%. And most damningly, dentists don't believe that this will improve access for patients. Only 3% believe that this plan will result in their practice seeing more NHS patients. Almost half believe it will do the exact opposite, and lead to their practice seeing fewer NHS patients. Not fewer existing patients to make space for those who haven't been seen, fewer patients overall. And to conclude, we also asked our members to sum up the plan in their own words, and this gives you a sense of the emotion of it. We didn't offer any prompts, free text. What we got was unambiguous. Cold fury from colleagues who have given up hope, frankly, of change. I read the words "too little, too late" over 100 times in responses. We counted the phrases used most often. They were, I quote, "not fit for purpose, dishonest, inadequate, rubbish, and I'm sorry to say, a joke." It's a pretty good summary of what the profession makes of this plan. It feels to me that this plan was not designed to rescue NHS dentistry. It was designed with the upcoming election in mind to try and limit the political damage the access crisis is doing to political prospects in constituencies. The measures in the plan make for a good press release, a nice photo opportunity, or something for candidates to talk about on the doorstep. But this recovery plan, to be honest, is not worthy of the title. The fundamental perversity of this system remains unchallenged. One colleague, to conclude, commented that you cannot rebuild a collapsed wall with a box of polyfiller. And that's precisely what is sadly being attempted here once again. More papering over of cracks rather than the decisive and fundamental reform that your committee recommended to deliver care to the millions of your constituencies who can't access NHS dental care.
Okay, that's the global view, and you've covered your survey responses. Is there anything, I know you don't appreciate the sum of its parts, but are there any parts within the dental recovery plan that you thought, thank goodness, such as registration of overseas dentists, such as golden handshakes, such as mobile vans? Were there any parts of that that you thought, yes, that's a positive step forward?
Yeah, I think the components of the Smile for Life programme are all things that we've called for many, many years, and I'm glad that we are finally seeing some movement on prevention in the early years. It's better than nothing, but of course it could have been far more ambitious, like the schemes in Wales and Scotland, where far more wide-ranging programmes have led to unprecedented improvements in children's oral health. And that the 165,000 children who this plan pledges to deliver fluoride varnish to, let's be clear, that is approximately 2% of all primary-age children in England. So in terms of scale of ambition, it just isn't enough. And we have to ask ourselves, how come after almost a decade and a half of these discussions, why is this happening now? I'd love to know much more about this proposal. I'd love to know how much money will be spent on this. Where is the money coming from? Will it be universal? Which children will benefit? I'd really like to know the detail of that.
Thank you. Rebecca, Healthwatch, you talked about policymakers better informing the public about NHS dentistry, and most notably people being aware that you don't have to register like you do with a GP in a locality to go to a specific practice. And you talk about, I think it's quite interesting, the government said in the dental recovery plan that it will roll out a national marketing campaign to encourage people who've struggled to find an NHS dentist to contact dental practices. You welcome that move. You said it's important for dentists to actively promote the availability of appointments to new patients and prioritise slots to people most in need, so people who haven't seen a dentist for over a certain length of time. Is that happening?
Thank you, Chair, for inviting Healthwatch to return to the committee on this important topic. And I'd like to offer some initial reflections.
Well, look, we don't really have time for pre-prepared reflections. We need to cut to it. So can you answer my question? Is that happening? Are dental practices in a position where they are actively promoting the availability of appointments to new patients?
Not that we have heard of. We are still waiting for that national marketing campaign. We met with about a dozen local Healthwatch who work in dental deserts about 2 weeks ago. And many said that their ICBs had been caught by surprise with the publication of the plan. And they didn't have details to hand on how a lot of the plan would be implemented. The most common question that Healthwatch continues to be asked is, how do I find out if my dentist is offering new NHS appointments?
Yeah.
So we believe that the plan should have required dentists to put a digital flag on their NHS website listings to indicate to the public, I am open to seeing new NHS patients who haven't been seen in the last 2 years, because we continue to hear desperate stories from patients about lack of access, including in the last week I've heard about one person who overdosed on prescription painkillers they'd borrowed from a friend in desperation to treat pain for untreated problems.
Wow. You know, we talk about dental deserts, and you just mentioned that expression then. Is there anywhere that isn't sandy? I mean, there are areas where there aren't dental deserts, right? I mean, I talk to colleagues in parts of London, for instance. My colleague from Sheffield is nodding, so we'll bring him in a minute. Are there areas where your members don't ask those questions?
So we have heard from local Healthwatch in all 153 areas about dental problems, but yes, the crisis hasn't hit England equally. You may have seen some figures that came out from the Health Service Journal yesterday, which shows that spending on contracted dental activity ranges from 70% in the quite populated West Midlands to only 40% in Somerset, I believe.
Okay, so yeah, it's very disparate, like the waiting lists in many ways, which is certainly not uniform in every single part of the country, which proving National Health Service is a name. Anyway, let's bring in Paulette Hamilton, and then we'll bring in my colleague from Sheffield.
I feel as if I might be repeating myself, so I'm going to ask the question. I don't know if it's Thea or Rebecca, so I'm not sure. Right, basically, what I wanted were the insights that you have had on the ground from people who have heard about this plan, or you have sat down and spoken to about the plan. A little bit like Shawn has said, what the dentists have been thinking. What have people on the ground been saying?
So as I said before, people are still waiting for the marketing. We acknowledge that the plan is only 6 weeks old tomorrow, so it will take time for the plans to filter through, but we just don't feel that there is much proactive communication happening. What we do know is people continue to face barriers to care. We recently carried out some cost of living polling, which shows that 20% of people were put off going to the dentist because of cost. That's up from 15% from the same poll that we carried out 12 months ago. And it's even higher for people who are in the worst financial situation. 40% of that group are put off going to the dentist because of cost.
And my second point is, what do you feel your role is, especially what is your role nationally and in local areas to assist the health service to actually get to a stage where you feel the information is being distributed so people do have the information they need? Because, no, I'll stop there. Thanks.
So local Healthwatch stand ready in every area to work with and inform their ICBs and to work with councils as well to share public opinion and to be able to tell them which communities and areas need the most help in terms of access. You know, if you look at initiatives like the dental vans, how are those decisions going to be made about where they park up in a community? How often will they be in an area? You know, who should they be targeted at? We've been told that the dental vans will be providing general dental services, whereas in the past they've been mostly targeted at bespoke communities such as asylum seekers or people who are homeless.
So can I, my last point, can I just challenge that? I really respect Healthwatch. I'll start there. But do you not think this is where you have a role to really get started in some of these areas and then ask for forgiveness if that's not where the government truly wanted you to go?
So if you mean local Healthwatch should be spreading the word about the plan, yes, absolutely, and that's what I think every single Healthwatch in the country published details about the plan when it was first published. But there is an issue there about raising public expectation. We need to understand which dentists are offering these new NHS appointments. If local Healthwatch can't get that information, how can they share that information with the public?
I'll stop there. That's a really good
All right,
point.
just
actually.
briefly give Thea a quick feel of the ball, because I know that Paul is going to go back to BDA on some survey stuff. You said, and I asked the Prime Minister about this just before Christmas at the liaison committee, you said in your report that NHS dentistry was at its most perilous point in its 75-year history, and obviously that was pre the recovery plan coming out. You, echoing what Shawn says about the survey, you said that it is, I think, not going to be anywhere like big enough to restore universal access. So give me your scorecard out of 10 for what you saw in the recovery plan against what you'd written in that big piece of work last year.
I'm a very generous person, so I'll give it a 3 or a 4.
Oh, excellent.
Maybe more.
That's you being generous.
It is. Well, compared to my
yeah.
colleague here,
Yes.
I think I'm probably doubling or tripling where my colleague probably would be, because there are some, as you pulled out in the conversation with Shawn, there are some things here which could work at scale. They could be good green shoots. But in terms of that root and branch overhaul of dentistry, and indeed the gripping of, is it a universal service for all, or is it actually going to be a good gold-plated service for the most vulnerable and those with the most need, and a service that is means-tested for others, it goes nowhere near to actually recognising or grappling with those really fundamental issues. So there are a few green shoots, potentially, if they're advertised properly, if they're talked about appropriately, if the vans are used in the right way. Sure, I'll give it a 3 or a 4.
Okay, fine, thank you. Right, let's bring in Paul. We just got to try and keep our questions and answers as concise as possible, just so we get as much ground covered. Go for it.
Thanks very much, Steve. And I was going to ask you, Shawn, about the survey, but you've so comprehensively.
Sorry.
No, it's absolutely fine, because I think it's important to get that out in front of the committee. But let me ask you a little bit more about the sort of issue at the nub of this, which is the UDAs in the contract. From your conversations with NHS England and the department prior to the publication of the recovery plan, was fundamental reform ever a possibility in your view? Was that where the department was at any stage of the process?
I think we had a very narrow window where the department's interest was certainly increased in an alternative system. But I think that window was very short and it closed very abruptly. And I think one of the greatest disservices, one of the greatest damages of the recovery plan is that it has, in effect, pushed meaningful contract reform, which, as I say, is the chief recommendation of your committee, has pushed it. And I know others will say, well, no, we will talk about it later in the year. We know what's happening politically later in the year. And realistically, do any of us think that a recovery plan and a new contract are going to be top of the list for discussion? So, as I say, I think one of the greatest damages and disservices of this recovery plan is perversely to have pushed legitimate contract reform, which is the only thing that will save this service. It has pushed that much further down the line. And clearly that is what is required. And to answer your question, I think essentially the interest in contract reform was very much diluted and distracted by the recovery plan.
Well, let me push you a little bit further on that, because you're right to talk about the sort of electoral timelines which frame this, but the government did say, as you just highlighted, that they are developing further recommendations for dental contract reform. Has the BDA been approached regarding the scope of that further work?
No. I mean,
have you been approached regarding the timelines for it?
No.
So that's a pretty meaningless statement in your view.
Yes. I mean, I'll leave you to judge how meaningful it is. But in essence, we have had no clear discussions about meaningful contract reform since last autumn, when all discussions is essentially stopped, and clearly work was then being done on the recovery plan, which had been announced last April. So once that work took hold, all meaningful discussions about contract reform have stopped, and we have had no discussion about timings, extent, ambition of that discussion. All we've heard is within the recovery plan, further discussions will happen later in the year. But it's such a loose arrangement, and frankly, we have little faith that it will deliver what is required.
That's interesting, because the government are not saying they're planning to develop. I mean, they said in the recovery plan they are currently developing further recommendations, so they've not engaged with you at all if that is happening, but you doubt it's happening?
No, I wouldn't go that far. I mean, developing a contract could have been one conversation. I don't know the extent of their conversation and their discussions, but we've certainly not had any of that information shared with us in terms of timelines, how meetings will be set out, what they're thinking of developing.
Thank you. Thea, can I just ask you briefly, I mean, what do you think the impact of delaying contract reform until 2025 is, and what would be your proposals in terms of how this issue should be resolved? What's the way forward for government and NHS England, in your view?
I think the impact of delaying contract reform is going to be the continued drift of, march of dentists away from NHS dentistry. And that has a catastrophic effect on the country, which has been laid out to this committee many times, so I'm not going to repeat it. But that is clearly what colleagues in the dental community are asking for, and delaying that is clearly the issue that is going to drive more and more dentists into private dentistry.
Claire, thank you.
Yeah, okay. Right, Rachel Maskell, please.
Thank you ever so much. I just want to start, Shawn, with you, if I may, about money. And I noticed in your opening remarks you were saying that you think that the plan could even be detrimental to the number of patients being seen. Could you set out why that is, but also where is the money going to be coming from for the increased UDA rate, for example, and the other fiscal measures mentioned within the plan?
So the fundamental problem with the plan is that there is no new money. And even the increase of the minimum UDA value is accommodated financially, afforded, if you like, by reducing the number of UDAs. So it's within the current contract value. So practices, I think, reasonably felt that this will mean more money. It doesn't mean that. It means that there are actually less UDAs to deliver. So their ability to deliver care to patients is actually reduced. And the new patient premium, so patient premium of £15 and £50 for band 1 and band 2 or 3, is accommodated within the current contract value. Now, the effect of that will be that if you are seeing new patients, which, as we all know, take considerably longer to treat very often, that will consume more clinical time. It will therefore reduce the number of patients, existing patients, that can be seen. And new patients inevitably, as I say, take longer to be seen. So the net result, many of our members who clearly know this stuff inside out and have looked at their particular practices are saying they're fearful that the effect of this could be, because it's not new and extra money, it is actually within contract value, will be to actually reduce the number of patients that can be seen. So that's where that statement comes from. The fact that there is no new money in an environment where over £450 million was taken out of NHS dentistry last year, it is bizarre. So even in a system where it's costing effectively less and less each year, and we talk about a figure of over £1.5 billion being taken out of NHS dentistry per year because of the effect of inflation and clawback, dentistry is getting cheaper and cheaper for government to deliver. It's getting more and more expensive for practices to deliver, and it's getting harder and harder for practices, obviously, to access NHS dentistry. And a final point, the reason NHS dentists are leaving the service is not because they want to. They cannot recruit and retain NHS dentists. If you run an NHS practice with a contract and you don't deliver the contract, the government will take the money back off you. You still need to pay your nurses, still need to pay the mortgage and all the other things that we know go into healthcare. Fundamentally, NHS dentists are struggling to afford to run NHS practices because it is not attractive enough, and I go back to the contract.
Thank you very much. Thea, similar question to you. I mean, in the light that we now know that the contract negotiations are delayed until 2025 or any implementation to that, what impact do you think that will have, and particularly on retention of workforce, and where's that going to lead us?
I think retention of the workforce is something that really needs to be focused on in dentistry, as it does across all of NHS workforce. But if we're going to retain dentists and we're going to raise the morale of the dentists that we currently have, unfortunately it's a bit circular. We come back to the contract, the way in which dentists are allowed to work, the way in which dentists want to work around oral health promotion, working with the whole patient, working with the most vulnerable. And if you don't have the capacity to do that, it is going to be very difficult to retain and to raise the morale of the dental workforce. You've got about 24,000 full-time equivalent dentists doing NHS work. You've got about 44,000 dentists in England. You have a workforce you could create incentives for and support to be more rapidly deployed into areas and with vulnerable groups. But to retain and raise morale takes you a bit circularly back to the way the contract is done.
Now, you see any indication that contracts will be handed back further again?
I'm sure they will.
Okay.
Okay, let's bring in Dr. Caroline Johnson, shall we?
Thank you. I wanted to ask you a bit about the contract and money again. It seems this is sort of essentially a supply and demand problem, where you have a lot of dentists, but they're increasingly moving to work in the private sector rather than the NHS. And indeed, looking through the number of dentists per capita, apparently we have more dentists per capita than we had 10 years ago. So theoretically, this problem should be easing, not getting worse. So a question for Shawn. Do you think NHS payments can ever compete with the fees that private dentists are able to charge sufficiently that dentists would wish to work for the NHS rather than for the private sector? And when you're looking at supply and demand, how much would you need to increase payments by to attract people over, if you think you could? What sort of level of massive increase in dentists would you need to bring the overall price down such that they could become more comparable? And who else could do dental work, such as nurses, and that would enable you to deliver some of the more straightforward work more cheaply?
Okay, so I'll take those in order. Do I think that NHS treatment can ever compete with the private market? Yes, I do. And the reason I say that is based on experience. So when I first qualified all those years ago in the mid-80s, broadly everybody worked in an NHS dental system. And broadly people were content. They moaned about this and they moaned about that, but that's the nature of life. Broadly, the dental profession worked in NHS dentistry. They did some private work, some practitioners were private, but there were very few. We had a system that was funded, was supported, and people saw value in it. They wanted to work in it. And it's all very well to talk about money in isolation. There's a lot more to running a dental practice in a local community than actually the cost of it. There is a tremendous moral, ethical, tie that health professionals have to their local populations. And I know that because I know how traumatic it is when practitioners feel forced out of the NHS. This is not something that people do lightly. So yes, I think if the NHS dental service was adequately funded in a sustainable way, you would see significant numbers of dentists wanting to work in it. So that's the first hopeful element, and that's the frustration, I think, for us as a profession, is that we need support about that in order for the profession to deliver NHS care. That's the first thing. In terms of what level of UDA value do I think would make a very good start, we formally gave evidence and suggested a figure of a minimum of £35 per UDA. And the reason that we chose that figure is that we thought it would impact significant numbers of practices. There is a direct connection between the minimum UDA or the UDA value that practices have and their ability to deliver UDAs. You can't escape from that because you cannot recruit dentists at low UDA values. We pitched at a level of £35 minimum UDA value that would impact significant numbers of practices. And the other area that was important for that figure is that it was completely affordable within the figure that is being clawed back out of NHS dentistry. So it didn't require any additional funding. We weren't being greedy. We were being realistic. If you can't spend the clawback money, why don't you spend it supporting those lowest supported practices? £35 was the figure that we set. And it's an interesting question, your third question about the numbers of dentists in the profession and the numbers working within NHS dentistry. And GDC have started to collect data in their annual returns that dentists have to submit. The workforce plan talks about increasing 8,000 whole-time equivalent NHS dentists to over 20,000 to make NHS dentistry more attractive. Do you really think that's feasible, where we're seeing NHS dentists leaving the NHS service? The idea that we are going to more than double the number of dentists working in the NHS without significant strides around contract reform is clearly fiction. So I think I've answered your three specific questions directly.
The other part of the question was about other people being able to do some of the more straightforward dental work. And just to go back to your issue on numbers of dental students, particularly as a part of the supply part of the market. During COVID, there was an issue with exam results that you'd be aware of, and there was therefore a higher number of students went into the system in 2020, 2021. Do you know how successful the training of that large number has been? Because there were concerns that it would be too many to train at once, wasn't there? And if it was successful, would you recommend it was continued rather than gone back to normal numbers?
I think there is concern that the experience that undergraduates are receiving clinically, is it preparing them as we would want for practice? Now, foundation training, vocational training as it was, certainly has a role in that, where undergraduates go into particular practices with support. But we clearly need to have a system where dental schools are producing undergraduates of a standard that is both safe and appropriate. I think, having spoken to the dental schools and deans and the people who are teaching undergraduates, I think they are concerned about, A, the capacity of dental schools to increase the number of undergraduates, because clearly that's going to need funding and support, and they are concerned about the numbers of academic tutors that will be available to teach those undergraduates. And the final point to think about, if you like, is once those undergraduates come out of dental school, they are going to work in a practice environment, potentially foundation training. And we're going to need a lot more foundation trainers to look after those dental students. All of this is possible, but it clearly needs a joined-up approach. And clearly, when they then move from foundation training to hopefully working in the NHS system, we will need, as a country, to commission many more, whatever it is then, and hopefully not units of dental activity, for these dentists to be remunerated and care to be delivered. Because at the moment, if we're going to move from 8,000 to 20,000 dentists, we need to significantly increase the amount of dentistry that is commissioned.
Right, and just the final part of the question, which was about the other people, other professionals within the dental service, being able to do some of the simpler, more straightforward tasks that dentists currently do.
Children's checkups, for instance.
Absolutely.
There's a big debate in healthcare at the moment about physician associates, and it's controversial. But there is there's a role for a wider disciplinary
There
team.
is certainly a role for skill mix within a team environment where certain clinical procedures are carried out by different members of the team. What is difficult within the current UDA system is actually making that work for various remuneration reasons as much as anything. And I would just guard against the sense that skill mix is going to be the silver bullet to everything. We fundamentally need to have the whole team engaged with an NHS dental service that's appropriate, but would not underestimate the value of skill mix.
Thank you.
Yeah, okay. Right, let's come back to Nuffield. We've got the Minister in next, we've got NHS England in next, and we've got the Chief Dental Officer sitting where you're sitting. What would you ask? When were you doing your report, what would you like to have asked them?
I guess I would start with reflecting on whether or not the Dental Action Plan, in their view, really does tackle the underlying issues that we all understand and we have described. Where they think it needs to go further, faster. Whether they believe universal dental healthcare is really going to be back and that there is a commitment to that and what that means. Whether they see the urgency of those who are the most vulnerable and those who are being failed the most, and whether they genuinely think that what's in the Dental Action Plan is going to meet those people's needs with the speed that is necessary, and why they haven't grasped the need for a more long-term and full review of the contract with the speed that has been asked for over really a very significant period of time.
Why do you think that is? When you looked at this in more detail than most, why do you think that is? Why do you think that hasn't been gripped?
You know what? I think it's neglect. I don't think it's a plot. Nuffield's view was that this was policy neglect and looking the other way. As you'll be more than aware as a committee, the NHS has quite a lot of things to look at, and that over a period of time, this is an area of policy that simply has got neglected, and that those who could chose to go private quietly. A group in the middle fought for what was left and the provision, and some people started to do DIY dentistry. And it was only at those points of urgency, like when the water was boiling, that it became really clear what those decades of policy neglect. Clearly, colleagues like those on my right have been spending a lot of time saying, hey, look over here, look over here. But our view, looking at it over a period of years, was this has just been neglected. I say just, but it's been neglected because there's been so many other things to look at. Never got to the top of the agenda.
Yeah. And just, Rebecca, to you finally, on the mobile vans. I saw a comment from, I think, the Hampshire Healthwatch, which obviously I'm a Hampshire MP, and the ICB have funded some vans. And again, I think the message that I saw reported was not enough, nowhere near enough. It was your understanding of these mobile units, so that, as I shall ask NHS England this, are they actually delivering treatment, or are they delivering toothpaste and toothbrushes?
We understand, we've been told, I think, by the department that they will be fully equipped with dental chairs.
Right. Yeah. And do you understand who's going to staff that?
We are told salaried dentists. We don't know where they're coming from.
Shawn, do you know about these vans? where the staff are the workforce is coming from to do it.
Yeah, so we understand that we're looking at between 12 and 15 vans
Right.
throughout the whole country. And we've done a little bit of analysis of that, and we optimistically think that might deliver between 50,000 and 70,000 appointments per year, and that's quite optimistic. Vans are clearly have a role in targeting specific vulnerable groups. That may be homeless people, maybe other groups. It is not the way to deliver mainstream dentistry to 12 million people who have unmet dental need.
Yeah.
It is clearly not again, I don't want to disparage it, but it is not the method to deliver the scale of care that is required.
But given where we are, is it not quite is it not a dentist's blue light that's going to go into communities that are underserved, not served, where inequalities are high, where people haven't seen a dentist in any form for a couple of years? I just wonder, is that not what's necessary right now, given where we are?
I don't think it's the answer, and I think there is a degree of there's a little bit of me that if I was working in one of those vans, I'd be a little bit fearful. We all saw the queues for the Bristol practice. Now, can you imagine working in a dental van that pitches up in any town, anywhere on Monday morning, and that will soon go around a town and wider areas.
A busy van.
It could be a rather unsafe environment, actually. What do you mean you won't see me? I've been queuing here for, and the police arrive as they did in Bristol. So I just reiterate, I don't think it is appropriate. I'm not disparaging it in the sense that it has a role in some places, but it is not going to deliver the scale of dental and oral health care that your constituents require. And in terms of a question for the Minister, I really hope you will ask her for some clarity on the figures underpinning the plan. So the Prime Minister, the Secretary of State and herself have repeatedly mentioned the figure of £200 million invested into this plan. But from the conversations that we've had, we understand that none of this is new money, and I really would like you to push her on this. It's funded entirely, as I spoke about earlier, recycling the current underspend and the current budget within dentistry. And so far, the Minister has refused to ask questions on where exactly this money is coming from, how much each parts of the plan cost. And on access, there's lots of figures flying around about access. We've heard 2.5 million additional appointments, 1.5 million courses of treatment, 1 million more patients seen. I'm frankly puzzled by how these figures have arrived at, and I would like to see the modelling published in order that we can be satisfied and reassured that the correct modelling has taken place. And I said these numbers, they make for a nice press release, but we all know, we've seen so many of these press releases, we do not know where they've come from.
Just a couple other quick things before we switch to the Minister. Do you have any liaison through the BDA with dentists who work in the military?
We have representation of military dentists, yes.
You will be aware that there's a health check, there's a health bar that people who join the services have to go through, and there will be a dental check that'll sit alongside that. And so for instance, if you'd had braces fitted, tracks fitted, you wouldn't be able to join the Navy for a certain period. And that bar is changing. But because we have this lag from the challenge of NHS dentistry, young people not being able to see a dentist who are now at the age, at least, where they may join the forces, is that impacting on, do you think, recruitment into the forces, and has that fed back to you?
Yes. I mean, this crisis is now working its way through society, in all streams of society, and we're seeing that within the military, where, as you say, it is imperative that our soldiers, airmen and sailors are dentally and oral health fit. And it is impacting on the ability to recruit, but it is also impacting on the number of days that those personnel are being taken out of service as a result of emergencies.
Yeah, that's a concern I have. And just finally, and we're going to bring in the other team, you warned, as the BDA warned, that is, about the EU phasing out amalgam and the impact of that. There's basically the silver filling that you give. The impact that may have on Northern Ireland in particular, because obviously under the protocol it is treated therefore as part of the EU. And Does the imminent phasing out of amalgam in the EU have an impact wider than Northern Ireland?
I think it will, because the supply of amalgam will be reduced because the demand for amalgam within the EU will stop.
So the market will disappear.
So the incentive to actually create a business to produce amalgam will decline, and the cost of amalgam will increase. And in Northern Ireland particularly, they are going to have to use materials that are mercury-free. And those materials take significantly longer to place clinically, which is creating all sorts of angst amongst dentists in Northern Ireland within a National Health Service system.
If there's a shortage of that product, and we've all been to the dentist where they've said you can have a silver filling or you can have a white tooth colour filling, it is the former is clearly cheaper.
Yes.
That could then push up the costs of dentistry across the board.
Absolutely. And particularly where amalgam is banned, which it is likely to be in the future, then the costs will increase.
Okay. Paulette, did you want to?
Yeah, it's a really silly question, but it's bugging me. Recently, Shawn, I didn't change GPs. My GP closed, and I waited nearly a year to find another one. But thanks be to God, I've got a brilliant one now. The question I want to ask: when I started with the new dentist, I had been with the old dentist for 26 years. She had got all my records, everything but everything was lost. Where does it go?
It won't have been lost, but what we don't have is a method where clinical records are automatically transferred from one dental practice to another because of the lack of IT development within the NHS dental service. They won't have been lost.
As part of the plan, has that been considered, anything around IT and the development of?
It's not a specific part of this recovery plan, but it's certainly something that we've mentioned on several occasions, that the digital investment within NHS dentistry needs to be made.
So, Chair, can I come back to you and say I think that's a big hidden issue at the moment, because nothing pertaining to people's records are being transferred anywhere when these dentists close. I just wanted to make...
Fine.
Sorry, thank you, and thanks,
Paulette. Okay, right, let's leave it there for now. We'll switch panels. So Shawn Charlwood from BDA, Rebecca Curtayne from Healthwatch, and Thea Stein from Nuffield Trust. Thank you very much for your time.
Thank you.
They've got no digital infrastructure. Is that what they're saying? The dentists have no digital infrastructure.
Network.
Yeah.
Just keep it rolling.
Is there individual?
We're still on. We're still on. Hi, Jason.
I'm fine. Thanks.
Morning.
Hello. Right, we are still rolling, as they say, so I won't say those words. Anyway, so we had Healthwatch in, and we've had the British Dental Association alongside the Nuffield Trust sitting in those seats just now. You just passed them on the way in. So our second panel today, which we're going to roll for maximum 45 minutes through till 12 o'clock. We have the Right Honourable Andrea Leadsom MP, who's Parliamentary Under Secretary of State, Minister of Public Health, Start for Life and Primary Care in the Department of Health and Social Care, of course. Dr. Amanda Doyle, OBE, who is the National Director for Primary Care and Community Services at NHS England. Nice to see you again, Amanda. And we have Jason Wong, MBE, who is the Interim Chief Dental Officer at NHS England. Nice to see you, Jason. Okay, right, we've got a number of questions. I'm going to kick off, and then we'll bring in Rachel Maskell and then Paul Blomfield, who I know has got to go very shortly, so we'll get to you as quick as we can, Paul. Let's just start with yourself, Minister, on contract reform, because obviously this committee brought out its big NHS dentistry report, and then you subsequently brought out the NHS dental recovery plan 6 weeks ago, I think it was born. there's been lots of talk about contract reform, and the plan says that the government's developing further recommendations for dental contract reform with any changes phased in from 2025 onwards. Can I just try and unpack the conversations that were had since you've been in office, and that you've inherited from briefings you'll have had as the plan was put together? Is that, you know, how did we get to this place where contract reform is still pending, really, and it actually says in the report from 2025 onwards. Where are we on contract reform? How do you view the situation as it stands? Because clearly the BDA are very concerned about it not being now, or yesterday actually. But where are you on contract reform at the moment?
Well, first, can I say thank you very much for having me today, and I really do appreciate the amazing work of this select committee. And for me, when I was first in this role, your report on dentistry was incredibly helpful, and it's steered a lot of my thinking. So tackling your question directly, contract reform is absolutely the priority. However, when I first came into this role, it seemed to me that dental recovery was even more, if you like, urgent than contract reform. So having got the dental recovery plan out the door, which is going to free up significant numbers of appointments, it's got the golden hellos. For me personally, the whole prevention, the Smile for Life agenda, absolutely crucial. So having got that dental recovery plan out the door, we are now turning seriously to contract reform. I've obviously heard from, I've had a number of roundtable meetings with dentists and stakeholders about the urgent need for contract reform. I completely accept that, and in fact I have my first serious meeting with stakeholders and practicing dentists on, I think it's March the 27th, and I'm hoping you'll be able to attend that meeting to talk about some of the issues. So recruitment and retention, obviously the way that patient treatment is funded, particularly the need to stabilise high care needs for more complex patients. So that work is very much underway, and it is my expectation that we will consult later on this year with a view to rolling out contract reform in 2025.
Okay. And does that move us fundamentally away from a units of dental activity to what we talked about in our report, which is a much more preventative, holistic oral health approach to dentistry? Because if you talk to dentists, as I know you do, we all do as constituency MPs, the issue that they have, and one of the main reasons they cite for leaving the profession, is the fact that they're UDA'd.
Yes, yeah. So specifically on prevention, I think the dental recovery plan very much shows the direction of travel. So the whole Smile for Life agenda is all about prevention. So if you start your life with good oral health because your parents understood about feeding, weaning, first foods, and then you have good oral health because in your early years setting your teeth are brushed for you by your nursery worker, your parents understand the importance of regular brushing and are shown how to do it, and we're working to get some sort of sponsorship for toothbrushes and paste for small children. You're given the information to spit, don't rinse. So our ambition is that by the time you reach primary school, it is for every child routine to brush your teeth twice a day. And what we do know is that if you start with good oral health, you're much more likely, from a prevention point of view, to go on to need less interventions later on. So prevention is absolutely integral to our plan, and that is already out there, and that's what we are doing. But to your sort of broader point about will we move away from UDAs, I don't want to second guess that. I would say almost certainly for complex cases. UDAs can work quite well for checkups, for example. I mean, my ambition would be to see a much, if you like, a much easier access to checkups. And as you'll be aware, one of the things we're doing in parallel to improve capacity is we are bringing forward a statutory instrument to enable dental therapists to do much more work, to free up capacity of dentists, and to enable dental therapists, for example, to be able to go into schools and brush milk teeth with fluoride varnish, for example. Also to do basic checkups and to provide oral health advice. So I think there could be a role for UDAs, but certainly where more complex cases are concerned, concerned, it will be the case that we will want to look at other systems. But just to come back to capitation, because I know that that's a thing that lots of people say, oh, we should have capitation. I have tried to dig into exactly the experience, because there have been pilot schemes, and Amanda might want to say a bit more about that. But capitation pilots that the department has held between, I gather, 2011 and 2022 actually demonstrated lower access for people in greater need. So, it doesn't seem to back up the fact that it would provide more access to people with those greater needs. So I need to understand that further. But really, if you like, I'm starting from a clean sheet of paper, talking to stakeholders and practicing dentists about what they would like from a future contract.
Okay, because Dr. Johnson was talking just in the previous session about that wider dental workforce doing some of the children's checkups, for instance.
Yeah.
And we see that in other public services, don't we? Where
yes.
Teaching assistants who work in schools who
exactly.
are not fully qualified teachers, and they have a role to play in your mind. And you say you're bringing something regulatory through
yes.
to allow that to happen. That's interesting. Just going back to Smile for Life. So all the stuff that you talked about, that differs from the Smile to Life programme, that because the NHS England website currently has a Smile for Life section on it. How does it differ from that? Would it be the stuff that you just outlined?
So, I mean, essentially it's building on what's gone before. Right. And I'm told by Jason's predecessor as Chief Dental Officer that there used to be a programme pre-COVID which I am certainly keen to reinstate, where, for example, every 1-year-old has a first dental checkup, right. just to make sure that gums are healthy, that little milk teeth are being cared for, that parents have the information and advice they need. But of course, the Smile for Life has a big opportunity because of the rollout of the family hubs, which are a one-stop shop. If you have a baby, go to the family hub, that's where you get support and services. And so right across my portfolio as Public Health and Primary Care Minister, I'm looking at what else we can deliver in family hubs, which I know have cross-party support, so that we can make sure that actually all of the education that parents need, as well as the support for good oral health, start in the very earliest days. So I think all of the ingredients are there, and as I say, I think the key has to be that by the time your child goes to primary school, they are already in the habit of brushing twice a day.
Yeah, okay. We're going to talk a bit about money. Others are going to bring in money and how the plan is funded and whether that's new money, existing money. But I'm going to just ask you, Amanda, from NHS England about money. There's been a lot of talk about underspends in this space, and we as a select committee, as you all know, in our report talked about that underspend should be being invested in dentistry. Did NHS England write to ICBs giving them the green light to use some of the underspend outside of dentistry?
So during 23-24, at the beginning of the financial year, we ring-fenced the dental allocation and encouraged ICBs to spend it entirely on dental services. Yeah. During the course of the year, it became apparent again for a further year that despite the fact that ICBs had committed every penny of that allocation in contracts, so at the start of the year there are contracts in place that commit all of the spend, but that money being used obviously is dependent completely on dental providers delivering the activity that they're commissioned to deliver. It becomes apparent during the course of the year whether that's happening or not, and for the past years, particularly since the pandemic, it's become increasingly apparent that not all of that money is being spent. Normally, if we applied a ring fence to funding, we would say at the end of the year, if you've not spent it on what it's supposed to be spent on, we would claw that money back centrally into the central pot. By November of last year, it became apparent that dentists in aggregate were under-delivering on the commissioned activity, and so that we would be in a position at the end of the year to claw back money from their contracts. They wouldn't have used all the funding that they were allocated. It also became apparent that there were huge financial pressures developing across ICBs for a range of reasons, including industrial action and other things that had impacted costs across the NHS. So what NHS England said was, at the end of the year, we still want you to spend all that money on dentistry. And in fact, I wrote out to ICBs to remind them of the opportunities they had to commission flexibly and use more of the dental funding on dentistry. But if for any reason they were unable to do that, we would not claw the money back centrally. Instead, it would remain with ICBs and would effectively offset pressures elsewhere in the system. So there was no point at which we said, please go ahead and use that money for something that's not dentistry, but we did recognise that ICBs have a duty to balance financially, and that underspends in one area sometimes offset overspends in another, as it will in any big organisation.
Okay, and that had ministerial oversight, did it?
That was agreed between the Department of Health and, well, no, it was an NHS England financial decision. But there was we did not write to ICBs and say, please go ahead and spend this money on something else.
With decisions come accountability, which is why you're here. I think our constituents will be slightly perplexed as to how we can be in a situation where so many MPs are hearing from constituents who can't get treatment from NHS dentistry, and yet they're unable to spend the money that's allocated for NHS dentistry on fixing their teeth.
Absolutely.
What would you say to our constituents? Because you don't have to face them on a daily basis. We do. We're accountable to them.
Absolutely.
You're accountable to us.
Absolutely. And I can understand the concerns of both you and your constituents in that case. The challenge we've got is that for various reasons, and particularly since 2021 during the pandemic, dentists have delivered a lower proportion in aggregate of their commissioned activity, and what we're seeing is a move away from a willingness or ability to deliver NHS care in favour of other activities. We recognise this, and some of it there's a complexity in that not only are there more people facing a backlog of trying to get care because of the dip that was necessary during the pandemic, but also dentists feel that they're not adequately remunerated for some of the packages of care, some of the course of treatment that may be required by those people.
Okay.
And that's why we've brought in the recovery plan incentives, so dentists will be more adequately remunerated, particularly for patients who've not had routine dental care over the past 2 to 3 years, and to incentivise dentists to deliver more NHS activity. And how much of the allocation we spend relies entirely on how much NHS dental activity dentists deliver.
Hold that thought, to be continued, as they say, but I'm just going to bring in Paul Blomfield, if that's okay.
Thanks very much, Sharon. I must apologise because I'm going to have to rush off after asking this question to Treasury questions. But can I just ask a couple of questions, Minister, about the recovery plan? Now, you claimed that it's going to deliver 2.5 million more appointments. That's an incredible number of appointments. Can you explain how you arrived at that figure?
That was NHS modelling that took into account the views of dentists and the usage of contracts and various other factors that came up with an assessment of what could be 2.5 million appointments or 1.5 million courses of treatment, because obviously many appointments are sometimes needed for particular individuals, and also, of course, reflecting the fact that those payments would be made where somebody hadn't seen an NHS dentist for 2 years. So, by definition, they'd not seen within the recommended period of time, so it may be the case that they would need more than one appointment. So it's a complicated set of factors, but at the same time it has quite a high likelihood of not being reliable, as is the case with all modelling. As a previous finance person myself, I can absolutely assure you that it's not rocket science, and it's more forecasting is a very tricky issue. So what in fact we're going to be doing is monitoring the spend over 24-25 on a monthly basis through the ICB's reporting to make sure that we can see blow by blow how much of their contracts to their dentists for NHS care are being used, so we can see exactly how much is being spent. And so on the one hand, we'll be able to report to members of the public who will want to have the confidence that there are dentists in their area that will take NHS patients, but we'll also be able to see the financial spend on a month-by-month basis, and then we'll be able to adjust the recovery plan, potentially increasing NHS contracts by up to 10% if we see that dentists are in fact delivering more than they're commissioned to provide as a result of the incentive there. So it isn't an exact science, just be very clear about that, as you would realise.
So could I ask that you share that modelling with the committee?
Amanda,
Yes, it's based essentially on what's the size of the under-delivery currently, so what activity do we commission is not being delivered, and if we delivered all of that, so if the measures we're taking to incentivise dentists to deliver all of their commissioned activity all were successful and all of it was delivered, that's roughly what it would translate into. And as the Minister...
It would be... Thanks very much. I mean, it would be very helpful if you could share that with the committee so we could have a look at it. But, I mean, that's quite an admission, Minister, because the 2.5 million was the headline that accompanied the recovery plan, and what you're now saying is it's not really very reliable.
Well, I mean, 2.5 million is the outturn of the modelling. I'm merely making the point that, as we all as politicians know, is that forecasting is not an exact science. So that doesn't undermine the fact that the modelling comes out with a number of 2.5 million. I am merely being cautious in saying that it could be more, it could be less, as is the case with all forecasting. It is not an exact science. Whether you're forecasting the debt, the deficit, interest rates, wages, they are never an exact science when you are forecasting.
Well, it's very helpful to be cautious with us. Do you not think it would have been helpful to be cautious with the public when you announced the recovery plan?
I think it's very important for people to understand the quantum. So when I say it could be under or over exaggerating, it can be either of those things. And as you will know, with economic forecasting, there's sometimes a span of potential outcomes to provide more detail. But actually, with a 200 million recovery plan like that one, which clearly would result in financial incentives that would increase dentistry activity, I think it is perfectly legitimate. And as we do in all areas of public policy, we put out the forecast, the number that gives people the idea of the extent of the increase, which is, as you say, quite significant and reassuring for members of the public, because actually at the end of the day, all of us as constituency MPs have people writing to us all day, every day, saying, I can't get an NHS dentist. So people do want to know that there is a material number. So, conversely, if we sort of said, well, we don't really know because we can't be accurate and blah, 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 that is not helpful to members of the public. So I think actually having a headline number is entirely legitimate. And I'm merely saying to the committee that it could be more than 2.5 million, it could be less than 2.5 million, but that is a best guess using robust modelling. So I think it's entirely legitimate.
Very much. Which part of the plan do you think is going to enhance capacity in practices or bring dentists back to the NHS?
So that's a really interesting question, and I think there's different aspects of it. So I think the golden hellos have the potential to really improve things. So 240 dentists who will receive £20,000 over a 3-year period to go to an area where they're really struggling to get the capacity. And that will be because there is an NHS contract and there aren't enough dentists willing to deliver under that contract. So that actually is hugely beneficial in just providing that capacity. So that's one bit. I think the mobile dental vans, which we anticipate around, I think 15 to 18 mobile dental vans in areas where perhaps they're more remote, perhaps there's less access due to transport issues and so on. Again, that will really improve capacity to very underserved areas. But equally, this additional payment of £15 or £50 simply incentivises all dentists to do more under their contract. And as Amanda said, the reason why for years we've had this under delivery on contracted UDAs is because dentists have found that doing private patient work has been more lucrative than doing NHS work. So it's a straightforward, we are effectively allowing them to take more remuneration for delivering more. So it'll be interesting to see, and as I say, we will be monitoring it monthly as to exactly what is improving the capacity overall. But I also think, the separate initiative I mentioned about the piece of secondary legislation that will come forward and enable dental therapists to take on much more work, that will also significantly increase capacity. And actually the numbers are roughly about 68,000 dental therapists and about 35,000 dentists on the dental register. So actually to enable dental therapists to take on more work actually really does expand the capacity in its entirety. But of course the point is you want to expand the capacity in the places that needs it. So places where they're already doing all of their UDAs and people aren't struggling to get an NHS dentist, and there are some places like that, you obviously don't have an issue with capacity. It's more in the places where they're struggling to recruit dentists, or they're more rural, or there aren't enough practices with NHS contracts. That's where you really want to expand the capacity, and that's why this is quite a comprehensive plan.
Thank you.
Thank you.
Thanks, Paul. Rachel?
Thank you, Chair. Jason Wong, as the Interim Chief Dental Officer, you've been reported as saying that the plan goes nowhere near enough within it, and also have expressed a sentiment around abolition of the UDAs. In the light of your position, which clearly is to advance the oral health in our country, why isn't the department taking on board your expertise in order to shape the dental plan and also to ensure that we get this contract right?
I think it's important to get the context of that particular conversation, which was based around actually contract reform as opposed to the whole dental plan and the whole of dentistry. I am entirely supportive of the recovery plan, and actually I made that clear in the comments that I made. There was a lot of commenting at that time that unless you get a complete wholesale change, there's no reason to cooperate with anything that comes out from the centre, which was the answer I was giving to a colleague in that particular place. In terms of the ability of the recovery plan, when I said nowhere near, it's about, are we looking for something that's a recovery plan, or are we looking for something that's sort of dentistry out? And that was in effect what the conversation was about. And I think that the recovery plan has some important components as the next step towards reform, that you can bring in reform, which has been worked on in parallel, that's already been announced, that will be consulted upon this year and coming in next year. So I don't quite see, it's not so much that the advice has been given and not being taken. What was also talked about, and we've talked about the UDAs here, and I think sometimes, regardless of what metric you use, and that opinions are split as regards whether capitation is the way to go. Anecdotally, people have approached me, and there seems to be a liking for fee per item from some colleagues as well. But I think that the UDA has probably got to a stage now where the brand is so difficult that I think that we need to find some way of getting out of that. But that, notwithstanding the reasons already given. And, in terms of the discussions we've just had in terms of the new patient premium, I mean, it's based around sort of, we've got some really good information out of Greater Manchester, which has led on this. They've had something like 80,000 on general dental services, about 76,000 patients, new patients into Greater Manchester alone on the urgent care part of that. So that's about 160,000 new patients in about 10 months in Greater Manchester alone. So there is some track record based around having a new patient premium being able to change behaviour. And I would also say very much, I think anyone that knows my record would be very supportive of the early years intervention that the Minister's just talked about. And also I think we quite often gloss over that workforce component, about how we can make both the dental therapists, but also we're talking about dental therapists, dental hygienists, clinical dental technicians to come in to being part of the NHS, and numbers have just been given by the NHS, and hopefully in the future also the enhanced dental nurses to come into that as well. And there are some significant parts, as Minister was just saying about the statutory instrument, that at the moment operationally that exemption is the one thing that's holding back, I think, hygienists and therapists making a bigger contribution. We're hoping that will come through, and that would then change that particular aspect. And also, I think, growing the workforce, the NHS long-term workforce plan, plus the provisional registration that's been put in there in terms of using international dentists as well. They're quite significant parts of it. So I think that it's one thing for a newspaper to catch on to one particular comment and one particular response to a great big thread, but make no mistake that I do back the recovery plan.
Thank you. And obviously the contract reform is the most important part moving forward. There's recognition right across the profession for that. Minister, I wonder if you can explain to the committee at this stage, within the plan and the proposals you put forward, where that money is coming from in order to fund those reforms, because certainly lifting the UDA rate, the premium for new patients, it seems to come out of the current contract, and I wonder if you could clarify that for us and explain where that money is going to be spent, the 200 million which was announced.
Yes, absolutely. So there's about 3.8 billion spent on dentistry, including community dentistry, so community services, so 3 billion on high street dentists, if you like. And the issue that we have is that for years there's been an under-delivery on contracted UDAs. So as Amanda explained, the ICBs will contract with dentists to deliver a certain number of UDAs. The contract is signed and agreed, the dentist will do that, and then they don't. And the problem is that until the end of that financial year, when they have to then give back the money that they haven't effectively earned because they didn't deliver the NHS care that they contracted to do, we have ended up each year for several years with that underspend. And so in a ring-fence budget, that underspend would be brought back. And as Amanda said, the NHS England decided to allow them to keep the underspend for elsewhere. So in bringing forward the recovery plan, what I was determined to do was to ensure that that underspend would in fact not exist anymore. So because what patients want is to see an NHS dentist. They're not interested in the money, the budget and so on. They just want an NHS dentist. And it is the case that if NHS dentists did deliver on the NHS care that they have contracted to do, then many more patients would be seen. So the idea of the recovery plan is to provide other incentives, other ways to spend that money that is ring-fenced for dentistry to enable much more access to NHS dentists. That is the idea of it. And as I say, we'll be monitoring on a monthly basis how that is working, and we expect to see that dentists will be delivering much more against their NHS contract, and with a view to later on in the year, should it be the case that they're right up against the top of their contracted UDAs, then it will be possible for ICBs to increase and to allow them to do up to 110% of their contracted delivery, which will be good news for patients.
Thank you very much for that answer. And just taking my area where there is an acute shortage of NHS dentists, it takes 7 or 8 years for somebody on a waiting list to see a dentist in a new area. They're paying already £28 as a minimum on UDA, and certainly the new patient premium will not cover, because people will not be seeing a new dentist within the time limit, because it's going to take 7 or 8 years to do that. So for patients in my area and other dental deserts, how will the plan benefit people which are waiting, undertaking DIY dentistry, or indeed just not seeing any dentist whatsoever? How will it bring benefit to my community?
So really, really good question, and there'll be lots of constituencies in the same boat, mine included. And the fact is, people in the first instance, they go on the NHS website, find a dentist, and they can't find a dentist because all of the dentists say we're not taking new NHS patients. So first thing is, with the new patient premium, which is £15 for a checkup, £50 if it goes on to further treatment, so that's a direct incentive to the dentist who has the contract to fulfil to the maximum of the contract, and then, as I say, potentially go to 110% of contract. So therefore, dentists who are currently thinking, do you know what, I'm not going to deliver my NHS work because I've got plenty of private work, they will be incentivised to think, actually, I am now more attracted to NHS dentistry. The statutory instrument that enables dental therapists to provide more care will also increase the capacity. We also have the golden hellos. So if they have an NHS contract but just not enough dentists to do that work, it will be possible to attract a dentist on a golden hello, a newly graduate
new
dentist.
Money.
Well, this is all coming out of the 3 billion that is currently so underspent. Each year it has been underspent. So it's new in the sense that it was otherwise not going to be spent on dentistry. So in that sense it's new. But it's part of the budget that for years now has simply not been spent on dentistry because there hasn't been the incentive, number one, and number two, the capacity in the system to actually deliver those contracted UDAs. I'm really trying to make this clear, and please do ask me again if that's not fully clear, but essentially it's two things. It's the incentive and it's the capacity. The recovery plan is trying to deal with both, and then the third thing it's dealing with is, of course, prevention, which at the end of the day is the biggest money saver, as well as, for families. If you've got good oral health, you start out with good oral health, you then don't need so much interventions later. But the recovery plan, I felt, was an essential first step in actually making sure that we're using the £3 billion on dentistry, which has not been the case in the past.
Okay, thank you, Chair.
Okay, that's really useful. Thank you. Caroline Johnson.
Thank you. Good morning. I've got 3 questions. The first one is for Andrea. You've talked about the importance of early years, and as a children's doctor, I sometimes see children coming into hospital to have sometimes many teeth removed under general anaesthetic, and it's pretty awful to think that children are coming in for that. You talked about children having their teeth brushed in nursery. The Labour opposition have talked about getting children's teeth brushed at school, but children are not at school or nursery every day of the week. They need to develop this habit every day, every morning and every night. Yeah. So to what extent does the government believe this is a parent's responsibility to ensure that small children's teeth is brushed? And what is it doing to reinforce to parents the importance of maintaining children's teeth both morning and night?
Yeah, so I completely agree with you that it is parents' responsibility to ensure that their children's teeth are brushed. However, with our Family Hubs programme, which is rolling out across England, and as I mentioned at the start, has cross-party support, those Family Hubs there are a one-stop shop for people with a new baby. And of course, oral health starts actually during pregnancy, because mum's own oral health is an important factor, because if mum has terrible teeth, then that will potentially harm the unborn baby in her womb. So very important for pregnant women to get their teeth checked, and that will be part of the advice that's given to families in Family Hubs. And as colleagues will know, dental care for pregnant women is free. And so then you go on to advice antenatally for feeding and weaning. We absolutely know that breast milk is the best nutrition for babies, but we also know that for some mums they either can't or choose not to, and therefore actual advice about infant feeding, bottle feeding, not giving your baby Ribena, orange juice, other things that you might have thought would actually be fine because it's fruit, it's good for you, it's all of the advice that parents need to understand, that actually babies ideally would have breast milk, and if not, then infant formula until they're 6 months old. And then for weaning, don't give them things with added sugar, don't give them certain processed foods which have far too much sugar in. So all of the advice that families need, and alongside that is advice on caring for babies' gums and milk teeth. And that does include brushing. And as I say, we're working in the department with some of the providers of toothpaste and toothbrushes to try and get packs for families in family hubs who might perhaps struggle to provide their own. But there will be tooth care clinics in family hubs and advice through dental therapists going to family hubs and early years settings. I mean, obviously, if your baby or toddler is in nursery, with the general physical and social care, feeding, changing nappies, etc., it makes sense for toothbrushing to also happen there. But recognising what you say, not all babies and toddlers go to nurseries. So yes, it's ultimately for us to give parents the information that they need to ensure their babies get good oral health right from the start.
Thank you, Minister. My next question is for Mr. Wong. Hello. Question is about fluoride and fluoridation of water. We've talked about prevention, and we have a separate strand that the committee is looking at the moment into prevention. What do you think the evidence is about fluoridation in water? Some areas, including mine, have fluoride in the water, others do not. Do you think this should or should not be more widespread?
I think it should be more widespread, and the plan does make a commitment for the start of that in the North East. I mean, while some of the evidence has been around for quite a while, that it's quite established that it is a safe and effective public health measure. And, you know, I would very much support the team that, in fact, as part of the Smile for Life, Minister's team is working on that right now, and I've been feeding into that actually just last night and this morning. So very much supportive of that. The evidence to me is clear. And always has been. And of course, in Lincolnshire, we have a split through the county, and you can see the results in children's oral health very clearly according to that split. And taking all the other factors across, I think it's a living proof, as well as Birmingham having had that for a good while, that it is something that we really should support a more widespread rollout of that.
Thank you very much. And then my final question, you've talked about incentives, Minister, for specific more vulnerable groups and more challenging groups to reach. I want to ask you about a specific group that impacts particularly my constituency, which is the armed forces. We know that the armed forces themselves, their service personnel, are looked after by the armed forces themselves with their own specific dentists. But the families of such personnel often have to move around the country, frequently at short notice, at the request of essentially the government. And the government put into law the Armed Forces Covenant because we have such a strong commitment to our armed forces. But I hear from constituents who have moved from other parts of the country that they're having to make many hours of round trips to attend their former dentist in order to maintain the NHS contract, because once they've moved, they're not able to get a dentist within the time frame before they're then moving again. So I'm interested to know what you're doing to support the families of our service personnel to meet the terms of the Armed Forces Covenant.
I think well, that is a very interesting question. And just recently, actually, in my constituency at Silverstone Circuit, we had a mission sport for veterans of the armed forces, and it was talking about the challenges that veterans have with accessing services when they leave the armed forces, sometimes with all sorts of specific challenges related to their service. And so I have looked into what specifically do we do for the armed forces, and as you say, it's not considered necessary to provide specific provision for armed forces, and I think there could be a case for doing so. But again, how dentistry works is that they don't run lists in the same way that a GP does. You do not have to be registered with a dentist in the same way you do with a GP. However, as we know, with often, whether it's a hairdresser or a dentist, they will keep a list and they will contact you with thoughts, and you will get preferential access by being a loyal customer. So the fact that they don't maintain lists like a GP would doesn't change the fact that very often once you've got a relationship with an NHS dentist, it's easier to stay with them and they will prefer you, and actually that is backed up by the evidence that it's harder if you've not got an NHS dentist to get one than to see an NHS dentist if you already have one. And again, one can understand that, because if you're a dentist looking at shall I take on a new patient, you almost sort of want to see what their teeth are like before you decide to take them on, and therein lies an intrinsic problem. So again, the answer is improving capacity, and what we need to see, that was why the dental recovery plan was so important, is because I completely take your point that people who are forced to move around with work, including the families of armed forces, they do therefore have to change areas at short notice for short periods of time, and because of the lack of capacity, they're not able to access an NHS dentist. So if we can improve capacity for everyone so that it's not so hard to get an NHS dentist, then that would solve the issue. But I do take what you say seriously, and I will look again at whether we should be doing something very specifically for armed forces families.
Thank you. I mean, I think, if you... I haven't seen a survey of it, and Mr. Wong may have done, but I would imagine that the service personnel families' teeth are in better nick than the public average, because the military life is a very disciplined and so forth, and so the idea that they're responsible and people who've brushed their children's teeth and brushed their own teeth would seem to me intuitive. But we do have a commitment to the people who are prepared to put their life on their line, that we will look after their families, and that means making sure that if we're asking their families to uproot themselves and their children every few years for our benefit as a collective, that we put them first. And I'd be really grateful if you could look at what can be done.
I certainly will.
To target some of that incentive money to those families that are being asked to move. Thank you.
Thank you.
Cool. Okay. Finally, Chris Green.
Don't finally. I do want to ask a question. I do desperately.
You okay,
We've got
mate?
5
All
minutes,
right.
2.5 if you want to share it. You sure? Okay.
Diverting.
Right. Thank you, Minister Letson. I've got 2 really specific points, and they're quite quickies. The first one is relating to the east of England. Currently, it has some of the worst outcomes, and going back to staff and the development of, there are no hospitals, dental hospitals built in that area for training and development. Is anything being planned to really plug that gap so we can offer the correct resources going into that area as a start point?
Yes, so that is all part of the contract reform consultation that will be starting, as I say, on, I think it's March the 27th is the first meeting with dental stakeholders and practicing dentists. And actually, it won't surprise you to know that I've had lots of approaches from different colleagues talking about the potential for a dental school in their area. And I am aware that a lot of graduate dentists will stay where they trained, and therefore, obviously, if you've got a dental school in your area, you're more likely to have the pick of the crop. Equally, there is, and we've not covered this yet, but there's also the very important point that at the moment, graduate dentists who cost more to train to the taxpayer than, for example, GPs, actually don't have any tie-in to do NHS work. And so commensurate with where do we have dental schools, we are actually going to consult on whether there should be a graduate tie-in to require new graduate dentists who actually do some work in the NHS as a part of their sort of payback for the cost of the training that they've received. And so the work on looking at new dental schools will all be tied up in looking at where we need dentists to be located.
Right, so my final question, it all ties in. It's really related to the last panel, and Thea Stein made a really poignant comment. It stuck with me. It said, dentistry has been neglected for decades. Now, as I told the last panel, I found a new dentist recently, and I was delighted. I could have kissed her. But anyway, and the point was, none of my records graduated over to her. And as part of what you plan for the future, I know that Prime Minister and others have really talked about IT. It was highlighted in the budget. What is being done to ensure that the NHS dentistry starts to really develop in the area around IT and IT development, so notes can be moved around with the patient, especially those that have many other conditions.
Yeah, so actually connectivity, as the chairman will appreciate, having had my role before, connectivity is so key in primary care, whether it's opticians, whether it's dentists, whether it's GPs, and then secondary care, actually providing that link up. And so I'm sure you'll be delighted that at the budget just gone, the Chancellor allocated £2.5 billion to improving technology, data, linking up different record keeping and so on within the NHS.
So will that include dentistry?
So it's the consideration
there
of
will
exactly
be new money for that in dentistry.
So there is new money to upgrade IT and connectivity in the NHS. The discussions about exactly where that goes are underway. Amanda, do you want to comment on how that?
It will include wider primary care, which obviously
so the
we are.
Investment in IT includes the whole of the NHS system. There's not been detailed plans made yet as to how that is applied, but it's really important, as the Minister says. General practice itself is a very highly digitised part of the NHS, but wider primary care, pharmacy, dentistry, optometry, much less so. We've made huge strides forward in digital connectivity for pharmacies as part of the Access Recovery Plan and Pharmacy First. But you're absolutely right.
I know about all of those. My point is, will dentistry start to see some of this? Taking you back to the fact that Thea Stein said dentistry has been neglected for decades. We do not want it to be continually neglected because something as simple as IT is not being planned for in that area.
So absolutely recognise that we have not, since the 2006 contract was put in place, we haven't fundamentally made reforms of dentistry until we started to implement the current changes, summer 22, then the recovery plan, then the contract reform that we're looking to consult on. And absolutely part of considering that reform will be looking at the enabling infrastructure, for want of a better term, which includes IT as well as the structure of the contract.
Paulette, I will take that point forward. However,
Please,
thank you. Yes,
because I will ask again.
Of course,
I think without
I would expect
taking
you
through
to.
The rest of it is really important. But you know, these guys want to feel like equals.
Absolutely understood.
Minister, I thought I might just give you a chance to give some hope to the sector, because you know a lot of work's gone into this plan, and over a long time, you know, Nuffield said it's not going to be anywhere like big enough to restore access to NHS dentistry. The British Dental Association said recovery plan not worthy of the title. It won't halt the exodus from the workforce. And Healthwatch England said a good start in the government's own press release. So, you know, it's a recovery plan. The clue is in the name.
Yes.
We had a pandemic which massively impacted close contact with clinical services, of which dentistry is as close as you get. It's a recovery plan, but I just wanted to give you just a couple of minutes just to give some hope to the sector who will be listening to this session that yes, this is a recovery plan, but you know it might be a good start, but it is a start and there's a lot more to come.
Yes, so you've said it yourself, Chairman, you know, this is better than where we were before. This is significantly going to improve the capacity and the incentive to dentists to deliver on their NHS contracts. It's also going to provide, as I've outlined, the golden hellos, the dental vans, the increased capacity through dental therapists. We've not talked about the overseas registration, but the provisional registration will make a big difference. Graduate tie-ins, looking at new dental schools. These are all parts of the review that I am going to start on, I keep saying March the 27th, I hope I'm right. It's certainly in March.
Sounds good.
It sounds good, and I hope you'll be there and you'll be able to report back to your committee. But please just work with me, is what I would say to the sector, is please, you know, give us the chance to reform the contract, totally understand, and I've heard time and again that the UDA isn't working, and I am absolutely committed to fixing this. I mean, I would really love to see that being a very quick turnaround. I think it's very clear to me what things can change that would make a significant difference, and I think we've already made a very good start on that just in the last couple of months. So I would ask the sector to stick with it. And I would just like to end on saying I think the Smile for Life is a game changer. Personally, I know I'm always banging on about babies, but I really do think that's where it all begins. And I just really, I think it's incredibly important that we focus on good oral health right from the start.
That's a good place to start. And it's a good place for our session to end. You can find us at Commons Health on X, where you can keep update with all the work that we are doing. Thank you for tuning in, and thank you very much to Jason Wong, who's the Interim Chief Dental Officer, Dr. Amanda Doyle from NHS England, and nice to see you. And thank you to the Minister, Dame Andrea Leadsom MP. That concludes the session. Order, order. Thanks. That is for your show.
Proceeding has ended. The 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 proceeding has ended.